Muy buenas noches a todos. Continuando con las ponencias del día de hoy, 26 de febrero, les doy la bienvenida en nombre de Jorge Herrera Ramos, señor embajador de la UNESCO y chairman de la World Congress of Neurosurgery UNESCO APSNet Walter y Dani. En honor al profesor Yassar Gil, a quien agradecemos por la organización de este magno evento. Asimismo, agradecemos a la doctora Deyanira Capi Casillas, chairman del capítulo estudiantil ANS y PN, al Dr. Salim Al-Rauf, chairman de la Walter y Dandy Neurosurgical Society, al Dr. Baba Kateb, chairman de la Society for Brain Mapping Foundation, todos ellos vice-chairmans del comité organizador. Y por supuesto, al Dr. Parménides Guadarrama Ortiz, chairman del Centro Especializado en Neurocirugía y Neurociencias México. Es para nosotros un honor el presentar al Dr. Hamed Nabil. Él es de Egipto, es doctor neurocirujano y profesor de cirugía en la Universidad de Egipto, con el topic Planeación preoperatoria para una resección de tumor cerebral. Doctor, le damos la bienvenida y es un honor tenerlo esta noche aquí con nosotros.
Hello everyone, good morning, good afternoon, wherever the part where you are watch this Congress. Continuing with today's program, on behalf of the UNESCO Ambassador Jorge Herrera Ramos and Chairman of the World Congress of Neurosurgery, UNESCO ASPNet Walter E. Dandy, in honor of Professor Yassar, who we thank for this great event, as well as Dr. Deyanira Capi Casillas, Chairman of the ANS APN chapter, Dr. Salim Abdul-Rao, Chairman by Walter E. Dandy Neurosurgical Society, Dr. Baba Kateb, Chairman of the Society for Brain Mapping and Therapeutics and the Brain Mapping Foundation, all of them Vice Chairman of the Organizing Committee, and of course, the Dr. Parménides Guadarrama Ortiz, Chairman of the Center of Neurosurgery and Neuroscience in Mexico. It is an honor for me to present the following presentation by Dr. Hamed Nabil, who is Neurosurgery Registered Royal Victory Infirmary, NUTH, Newcastle upon Tyne, UK. Master in Surgery, Mansoura University, Egypt, with the theme Preoperative Planning for Brain Tumor Resection. Now, Doctor, we can start with your presentation.
Okay. I would like to have a chance to thank you for the invitation and all the organizing committee, and I will share my screen now. Yeah, so our presentation today is about the preoperative planning for brain tumor resection. The most important in planning always depend on imaging, and there are a lot of modalities of imaging like MRI, brain, CT brain, cerebral angiography. There's some modalities like CT angio, MRI angio, and TSA is a distraction subtraction angio. And the more recent technology of imaging guided resection of brain tumor and the virtual reality application in brain tumor surgery. So we'll start with a few words about each modality. The CT brain is can help to diagnose some tumors, especially if the hemorrhagic brain tumor like metastatic melanoma. Can detect also calcification like oligodendroglioma, and in meningioma, sometimes you can see the bony hyperostosis which is present. Also, it can be a contrast enhancement study to just diagnose contrast enhancing lesions. So I have some few CTs. The first one is this one is a plain CT head. This, if you see it, this is a normal brain, and this is the ventricles. These are all normal areas, and if you notice, there's some abnormality here. It is different heterogeneous densities some are hyperdense and some isodense. Isodense is very similar to the brain, the color of the brain, and hypodense is like more towards black. And hyperdense is white, like a hemorrhage. This is the second one is very similar, but with contrast. If you see here, this is the same lesion here, which take ring enhancement. We call it ring enhancement because it is enhancing around the periphery of the lesion, with the center which is not taking contrast. And there is some edema around here, the swelling, which is the effect of the brain, of the tumor on the brain tissue surrounding it. If you see here, this is another CT scan showing hemorrhage inside the tumor. It can be metastatic melanoma or any other metastasis. And the last one here is having this, you see here, the frontal area is having a calcified lesion, mostly oligodendroglioma. If we come to the second modality of imaging, which is the most important, and if this is a imaging type of study for brain tumors, it helps the diagnosis of brain tumors regarding the location, the size, if it is intraaxial or extraaxial, and relation to surrounding to important arteries and nerves. And I mean by intra or extraaxial. Intraaxial means it is inside the brain matter. It's arise from it. The extraaxial, for example, it's comes outside the brain, like it's coming from arise from the skull, or a meningioma arise from the dura covering the brain, and it displaces the brain to the other side or to compress it, so it's not infiltrating. The different sequence are T1, T2 weighted imaging, flare, and contrast imaging, and more DWI is diffusion weighted imaging, MRS, and functional MRI and DTI, which are more advanced technology to detect other functional areas. If you come to the first three, T1 and T2 weighted imaging and the flare, the basic ones are T1 and T2, and the difference between them is the time of transmission given. The T1 imaging, the water is dark, so you find the CSF looks black. In T2 imaging, the water is bright, so it is in contrast to the other one. The CSF will be white. The flare image is very similar to T2, but the CSF is dark, and I'll show you some scans now. So if you can see here, this is a T1 sagittal image, and if you see there is some abnormality here, abnormal area, also heterogeneous, slightly darker than the other brain, so it will be hypointense. We say hypointense in contrast to the CT, which hypodense. And this is T2. We agree that this is the CSF is white, and this is the abnormality again. It's each sequence have a different shape and different character for the tumor, and T2 is useful because you see the surrounding edema, which is a swelling around the tumor. And this last image is a contrast, as we see here. This is the sinuses and sub-blood vessels is white, so it took a contrast. So it's the same tumor, which is taking also ring enhancement or enhancement or contrast enhancing around the periphery. When the center, there is no enhancement, but there is some solid areas to enhance here. So the enhancement means these areas are more active and means more vascular, and it indicates more activity and more growth and multiplication, which sometimes indicate it is going to have a malignant transformation. If you come to the other modality of diffusion weighted imaging, this is a technology that depend on the rate of movement of the extracellular water and the rate of its diffusion through the tissue. And the most important thing, it differentiates between a necrotic tumor versus a cerebral abscess. They are very similar in MRI the usual sequences, but if we want to differentiate, we will use the diffusion weighted imaging. The tumors usually have fluid, so there is no restricted, we call it no restricted diffusion, and the abscess you will have a characteristic of restricted diffusion and significant reduction in ADC value. I'll show you the scan now. So here we can see here, this is, as we agree, this is a CSF spaces and the sulci around the gyri here. So the gyri is dark and this is the white ones are the sulci between them. So the white CSF in T2 and this is T1, but with contrast. As we agree, there is some contrast here of the dura and the venous sinus. So we find in these two pictures, you will find, we call this ring enhancing lesion because enhancement making like a ring, and it's very similar together. But how we differentiate, the differential diagnosis is an abscess or a tumor like metastasis or high-grade glioma. So we differentiate by this is called the diffusion weighted imaging. You will find the cerebral abscess is bright and more white. So this is called restricted diffusion because the water cannot go inside if there is pus. So the limited diffusion for that. And while in metastasis and the other tumors, it is like black and there is no, this means no restricted diffusion. So if you have a lesion like this and you have a suspicious, if it is abscess or a tumor, you should do the DWI or diffusion weighted images to detect it. And this is important for preoperative planning because the cerebral abscess will need aspiration while the tumor needs like surgical excision and a different operation. The other one is called the MR spectroscopy, and it is analysis of the different metabolites within the brain, and can be used to diagnose, help in diagnosis of certain brain tumors, as well as directing biopsy and help grading and treatment assessment as well. The major metabolites which we measure is N-acetyl aspartate, which is a marker for neuronal tissue. So if you find the normal tissue, this is a marker for it. The choline is a cell membrane marker. So if there is a cellular tumor, so it will be the choline will be high because it's not neuronal, it's cellular. The creatine is energy marker. This means metabolic and energy process, and lactate is a metabolic acidosis, and lipids is tissue breakdown and cell death, like in abscess, because this is a breakdown. The MR spectroscopy in most brain tumors will have a high choline and low creatine. This is a ratio, choline to creatine ratio and choline to NAA ratio, because in the tumor, as I said, it is a more cellular, so the choline is high, which is indicative of cell membrane marker, and the NAA is low because it's a normal neuronal marker. So in the tumors, the tumor cells replace the normal cells, the normal neuronal cells, so the choline will be high and the NAA is low. In addition, this can be helpful because, as I said to you before, we remember to differentiate or to detect the if there is a malignant transformation of low-grade glioma, because sometimes in low-grade glioma it transforms to a malignant one, and you find a new area of contrast enhancing, and you are not sure if it's malignant or no. So sometimes it helps in that. And the other thing is CNS lymphoma also. It has a similar picture to other tumors, but there is lactate lipid peaks are present in 90% of cases. And the last thing, in brain abscess, the succinate and lipids will be high. As we said, the lipid will be the tissue breakdown. So this is a picture for MRS. So what we see here is a MRI of the brain, and we see here a large area of, we say it's hypointense because it is dark compared to the brain tissue. And you see here there is an area of contrast enhancing. So to make sure it's or to detect if this is have a malignant transformation, we do the MR spectroscopy and analysis, as I said to you. So you will find here the choline is high, peaking, and the NAA, the N-acetyl aspartate, is low. So this is the ratio is high. The choline to NAA is high. So this indicates it could be a malignant transformation. The next modality is the functional MRI imaging, and its importance lies in that the extent of resection of the tumor is a main factor affecting the long-term survival and outcome in brain tumor, and can be determined only on the basis of proximity of the lesion to elegant functional brain regions. So preoperative imaging are increasing, being used to outline eloquent brain areas prior to resection, including it has two modalities: functional MRI and DTI, which will come later, and they are based on the blood oxygen level, contrast effect, and physiological neurovascular coupling. This means if we are, for example, we ask the patient to do a cognitive task, for example, to talk or to move his hand, and then in the area of speech or area, according to if he talks, the area of speech will have activation of this brain area, and there will be increase in the networks of these brain region, and in turn there will be increase in the blood flow to this area, which is resulting in increase in the oxyhemoglobin level in this region. That's why it can be detected on the functional MRI. So it depends on the on our cognitive task, either speech or something else. So we have two domains to test, either for sensory motor area or domain, and for language domain, and they found that the functional MRI combined with invasive techniques to detect sensory motor areas have typically higher in sensory motor than with language area functional MRI. So it's more sensitive in detecting the sensory motor area rather than the language area. And in some studies, as we see here, the effectiveness of the functional MRI and localizing the sensory motor area reach up to 92%. For the motor functional MRI compared to this electrocortical stimulation mapping, which is a type of invasive technique, as I said. And with the use of 3 Tesla imaging, this proportion comes to, or the percentage comes to 100%. So it's great. In language, it's mainly the modality of choice in detection of language laterality. So it's easy to just detect if it is left or right, but as I said to you, less sensitive in the language. And when we see this lesion near a speech or near a motor area, we just do this functional mapping to detect exactly where is the functional area of speech, for example, and they delineate it for us or make it more clear. And sometimes because you don't want to injure it, or you don't want to have a problem with the speech after the operation, usually some people, if according to patient selection, if he is well selected, he will go for awake craniotomy for the tumor. So the patient will be awake after being anesthetized for some time, and then he will be awake while we are doing the surgery. And after removing part of the tumor, we ask him to do the function, for example, to talk, to phonation and other things. And then it has been detected with intraoperative monitoring to make sure that it is not affecting the area. So it is very important for preoperative monitor planning for surgery. The other modality, which is closely related to the previous one, is the diffusion tensor imaging, and its value is to just to evaluate the white matter structures and function in healthy and disease status, and to define the anatomy of the elegant white matter tracts for surgical planning, like corticospinal tract and visual tracts and other important areas. Here, here we can see on the left side there is two as MRI imaging, is T1 and this is T2. There is a large area here, a cyst. Why is a cyst? Because it seems to be like cystic area here with a small solid area, and this is a contrast enhancing, and this is the shape in T2. And in this area on the right, on the left side, sorry, it is distorting the sulcal pattern, and you cannot decide whether where is the motor area, where is the central sulcus, and difficult to know where is it. So we do the functional MRI with some function for like finger tapping. So can be delineated with this pink area, and we can see now this is a tumor, and it's on the top of the tumor. So this area is displaced by the tumor upward, and we know this is on the upper border. So if you do surgery here, you have to make sure you don't injure it, or you take care while you are resecting this area. And if you see it here, it is easy to delineate or detect. This is the central sulcus, and this is the pre and post central gyrus, the motor and sensory area. And if you have another function, with this one is the finger tapping in orange, and this is the foot movement, because and you see both of them are deviated and displaced by the tumor. And you see here, so this is a motor area displaced by the tumor, and this is the corticospinal tract in blue, comes from the motor area, come down to going to thalamus and then the spinal cord. So it is displaced also medially by the tumor, as you said here, just displaced to this side. So you know now you can just go to the tumor while you are doing surgery from this side, but you cannot do from here. And to make sure the extent of the resection, you cannot go deep to this area, you cannot go to this area while dissecting. Another modality is the vascular imaging. Has some modalities of CT angio, MRA, DSA, and others. So it's identifying the feeding arteries and the draining veins of tumors, and also to detect the important arteries and vessels related to the tumor or on its surface. And because some of them is not feeding the tumors, so we cannot injure it. It's a cortical vein or a cortical artery that supply or a cortical area, so it has to be very cautious with that. Also, if you have a feeder, sometimes they do embolization or clothing this artery with a material, so the blood supply to the tumor by closing the feeding artery doesn't reach the tumor, so it doesn't go there. So it if you do surgery, you will do it on an avascular tumor, which is much easier than the vascular one, which have a high risk of bleeding. And there is more advanced technology of integrated imaging of CT and MRI to help guide the surgical approach and to preserve the important arteries and veins. So this is called the DSA, digital subtraction angio, and it's done through a catheter through the femoral artery, go all the way down to the aorta and then the carotid, and we inject a dye and it will appear in the brain. This is a carotid artery, the left side, and this is a bifurcation for the middle cerebral artery and the anterior cerebral artery. And you have the segments M1, M2. This is the first segment, and then the bifurcation here. There's some in the insula, there's M2 branches, and then the cortical branches at the on the cortex here, and in in the anterior cerebral artery will have A1 segment, and then will meet the other side by anterior communicating artery here, and then will continue above the corpus callosum by a pericallosal artery, and another branch is the callosomarginal. This is another side view. You can see the carotid here, and this is the bifurcation. This is the middle cerebral. This is the anterior cerebral by its branches. So you will have a lot of branches here to see, and this is very helpful to detect, to know, to get an idea about the vascularity of the brain and the relation to the tumors before starting the surgery. Here, I just mentioned to you about the integrated MRI and CT. This is a CT first. Show you the anatomy of the circle of Willis. We know the circle of Willis is anterior part and posterior part, and communicating together with the PCOM, posterior communicating artery here. So we have the cavernous carotid in the cavernous sinus going to the clinoid and come up, divide to the anterior cerebral and middle cerebral, and this is on the other side cavernous, and making a S-shape clinoid, and then making divide to the middle cerebral and anterior cerebral. Both anterior cerebral arteries have a connection between them. This is the anterior communicating artery, and it's common place to have aneurysm occurrence. And you see here there is an opening in this area, so it's fenestrated A1, we call it. It's some like anomaly, but it's not sometimes it's not significant. The other one is from the carotid, the same comes like the posterior communicating, which is connected to the posterior circulation through this is the posterior cerebral and this is the posterior cerebral, comes as a terminal two branches from the basilar, and there is another two here, superior cerebellar and superior cerebellar, which are the two branches below them, below the posterior cerebrals, and we see the vertebral arteries here, which join together to form the basilar artery. If we see the integrated image, for example, this is a parasagittal meningioma, which is meningioma near to the midline, and it is in close relation to this superior sagittal sinus, which is one of the main draining venous sinuses in the head. And you see here the veins draining to the sinus. You see them in relation to the tumor on the posterior, and here in the posterior and the medial part. Here, this is the draining veins. So this is only cortical veins coming from the cortex here, and it is crossed over the meningioma. And if it is injured, it will cause a major problem like a venous infarction. So we have to be careful and preserve them. So this is very important also to detect the venous relation to the tumors before surgery. Another interesting thing here, this is meningiomas, different types. This is parasagittal, always come to the midline, and this is the superior sagittal sinus, so it is very close to its wall. This is another parasagittal meningioma. This is a skull-based meningioma, sphenoidal meningioma, and this one is a parasagittal meningioma as well. And if we do the DSA like the one we did before to check the vascularity, we want to check this one has no vascularity, so it is grade 0. This has started to increase, so it's grade 1. This is grade 3, more than the previous one, and this is more flush of vascular supply or blood vessels, so it's grade 3. So it is useful to detect the vascularity, how the grade of vascularity, and to make sure, because some tumors have a risk of major bleeding if we don't deal with that. So because of that, we just sometimes get benefit from preoperative embolization, as I told you before. And if you see here, this is the middle meningeal artery, and this is the feeding artery from it going to supply this meningioma. And if you see, this is the early arterial phase, and this is the late one. So there's blush of, as I said to you, like sunset, or what they call tree plus of vascularity. And if you see here, after just two embolization, means they close this artery. See, there's no vascularity come to the meningioma, and you cannot see it. So it is a vascular lesion now, and it is safe to be removed, and it's much easier. Another one is the perfusion MRI imaging, which can be done in by 3 methods. 2 of them need contrast, and another one, which is arterial spin labeling, doesn't need contrast. It is important because as the tumor grade increase, we have tumors of grade 1, grade 2, grade 3, grade 4, for example, for gliomas. And as the grade increase, the relative cerebral blood volume ratio increase as well. So the higher the grade means the tumor is more active and more having more mitotic figures, and it has more blood flow to go there. Also sometimes helpful because the lymphoma has it's not a specific character, but it demonstrates an increased signal in the recovery, phase due to contrast material leaking within the interstitial phase, and this helped to diagnose lymphoma. And as I told you, the different, because if you have a tumor and you are not sure if what it's exactly, and you have a suspicion of lymphoma, you can just do the test to try to decide if it is lymphoma, because it is usually have a good response to medical treatment and steroids. But the GBM or glioblastoma, which is a malignant tumor, need total resection or a maximum resection with safety margin. So the perfusion imaging is the one on here. So we have the same 2 cases of meningioma here, and we know the DSA now. This is grade 1 because there's some flush here, and this is grade 3 vascularity. So if you compare it to correlate it to the perfusion, you can see this red area or pink areas of increased vascularity. This is more apparent more here and more vascular. That's why the color is more evident. So it is very useful to know also before surgery how much vascular is the tumor. We have also the more advanced imaging technology to help us to plan for surgery, like the image guided surgery, which is advanced techniques valuable for neurosurgery. It's a computer-based neuro navigation and consisting of tracking system that fuse with a conventional and advanced imaging. So you have the normal MRI, you fuse it with the specific imaging. They do it for this this system or software, and then you can detect exactly where is the tumor, and it helps you a lot to localize it and to know exactly to localize where the craniotomy should be done. So there is a camera to displays to the patient so that the surgeon can track the tumor and the patient position on a computer screen using a live pointer. I'll show you now. So this is intraoperative in theater. This is very similar to the one in our institution. So the surgeon, you see this, it's not very clear, but this is the pointer, registration pointer. And there is a camera here. And he is using it to localize where the tumor is. So if he's moving this pointer, the movement can see here. So it moves on around the skull here to just delineate where is the tumor. And this we can see here the patient on table, and we see the camera and the monitor, and this is the the array, and this is called the marker spheres. So the camera see this marker spheres, and with the registration on the head of the patient, the screen, you can see the tumor exactly where it is and to decide where should we do the craniotomy. And this is how to register, either by detection marks to stick on the head of the patient, or like by a laser or pointer laser to detect, to just delineate some points here on the face and the forehead of the patient. And then if it is registered, all data go together to the imaging, and you can localize where the tumor is. So it is very useful as a planning for surgery. And the more advanced is the virtual reality and 3D technology. It helps you to see exactly 3D orientation of the lesion and the critical structures before surgery, and approach planning in 3D and correlated other imaging. Also virtual stimulation, you can just simulate the craniotomy you are doing before the surgery to check what is suitable option for you. This is how it looks like intraoperatively. So there will be a 3D glasses, and there is a controller, and then it is very similar as you are doing craniotomy. You go as if you go inside the skull, you see the tumor and its relation, and it's very clear as if you are inside the skull. Here you can see here also a simulation for craniotomy. It just let you virtually take off the bone, starting from the skin to the bone, and go inside. You find this tumor and you detect the relation to the arteries and the important nerves and arteries of the skull base. So you can see this one before even surgery, and then you decide which craniotomy are you gonna do and how much extent it is. So it helps you to just delineate it, because most tumors have a distorted anatomy, so you cannot decide where the arteries or the nerves. So we have some example cases on what we have done. So here, sorry, there is an anterior cranial, for anterior cranial fossa lesions. You see here, this is T2 imaging. You will find a large lesion here. And if you see the origin, if you go to this scan here, this is a CT scan with, you see here some hyperostosis or thickening of the bone at the base of the skull. This is where the tumor arises. And this is, we call it nodal plano-sphenoidal meningioma, extending to the frontal lobe. And you see here, there is two different intensities, one hypo-intense and one hyper-intense, slightly to the brain. And these two are contrast imaging, showing homogeneous enhancement of the tumor. And here you see this flare image is, sorry, the flare image showing the edema around the tumor here. And you see also in this image, you see how the CSF cleavage forming a rim around the tumor here. So this is considered a cleavage line if you would like to go around the tumor and to dissect it. So every image from here, every information you take from the imaging help you inside while you are doing the surgery. Also, you find here that this, you see, these two arrows is the dilated olfactory grooves where the olfactory nerve is, and because it is affecting the shape of the bone, this means it's chronic and it has been for a long time slowly growing tumor. The other image down there is a MR angio, which is showing you the displacement of the arteries by the tumor. So this is a place where the tumor is, and this is internal carotid arteries displaced downward, and this is anterior cerebral arteries. When we saw them before, it was going like this, but it is displaced posteriorly, as you see here, and upward. So it is distorting the shape because it is distorting the anatomy. It's very important to know where are the current situation, where the current side of the artery in relation to the tumor, so you can avoid injuring it. If we go to the sellar and suprasellar lesion, we have like a craniopharyngioma. So we have T2 imaging. When we know that with T2 imaging, why? Because the CSF is white here. So we have a mixed lesion, a solid part and a cystic part here, as you see. And when you take a contrast, the solid part enhancing, and the other one is not enhancing, but only there is some rim enhancement here around the margin. And you see here the displacement of the pushing up the optic chiasm and the relation to the arteries here. If you notice, this is what we call signal void. You see here these two carotid arteries, one here and one there, and this is anterior cerebral, one here and one there. So it is displaced, and see it's concave and distorted by the tumor here. This is a tumor and distorting it up. If we see these two imaging, this is the functional MRI. As you see the DTI, or which, as we see, detect where the white matter fibers are. So we see now here the corticospinal tracts. We see this is the anterior commissure. We see that the tumor is affecting the shape of the anterior commissure, and it's pushing it up and pushing it forward. You see it is making it convex forward and convex upward. And you see here the optic chiasm and optic tract. If you see the image is very similar to this one. So this is anterior commissure displaced and pushed upward by the tumor. And here we can see the MRA. You see this is very similar to here. This is a tumor, and this is the displaying or making bifurcation for both A1. So if you do the angio to make sure, so you will find the bifurcation of these anterior cerebral artery segments caused by the tumor placed here, as we see there. If we go to the posterior fossa, lateral approach, a common tumor is the vestibular schwannoma, which arise. This is a posterior fossa, this is a cerebellum, and this is a brainstem. If we see the skull base, you will find a canal here, which is so the origin of this tumor is from this canal, which is there is two parts, one intracanalicular part, and one is a cisternal part. So the one inside the canal is the canalicular part, and it making like a cone. And this is ice cream. It is like ice cream shape, and this is a cone for it. Okay, so it's a cone and ice cream. And if we see here, this is how it has effect on the brainstem. So you have push the cerebellum to this side, and this is the fourth ventricle. See the shape is distorted, and it push also this is the brainstem pushed to the other side because it should be in the middle, in the midline here. So the tumor have grown and pushed the brainstem to the other side. Here we can see the where the origin of the canal comes from. The nerve these are tumor come from. It arises from the vestibular nerve inside this canal, and because it arises from there and it has been chronic, so we find this enlargement of the internal auditory canal. This one, as you see here, compared to the other side, is narrow, but this one is wide because where the tumor arises and it spread outward. And the porus acousticus as well. This is where the nerves go as well inside. And if we see the angio for this tumor, we know, we see this, you see the vascularity here, but this is the tumor where the tumor is, and the vascularity is considered hypovascular. There is no much blood supply to the tumor, but you see here there is artery, it stretched the arteries and the vessels around it. So you see the relation of these vessels to the tumor, as you see. There will be the supratentorial or convexity lesions. We can see here in this CT scan, there is, see as a F2 loops here, cystic lesion, because the solid should be different from this one. There is a septum in between, and there is some tissue here. This is solid, and you see this two areas is very similar to the bone here. So it is a calcification in this solid part, and this is how it looks like in the T2, because we know now that T2, this is T2 because CSF is white. And if we see the contrast here, can see the solid part taking contrast enhancement, and we see the margin of this cyst is enhancing as well. If we go to the functional MRI, we can see now this area of the left hand. We can see the color in orange, or it is red yellow. This is how we detect it, as we said, either doing finger tapping, and we detect, as we said, the blood, the relative CBV or cerebral blood volume to this area, and we see it is displaced by the tumor to the outside. All this area is occupied by the tumor, and it's pushing this motor area to this direction. And we see also this white fibers is the corticospinal tract, and it's displaced also by the tumor here, and it's surrounding it. So if you are doing surgery, you don't want to go to this side. You can just approach the tumor from more front. Don't go to the posterior part of the tumor or the back, because it is related to the corticospinal tract, and you cannot go there. This will injure the hand movement area, so the patient may have paralysis after. So this is the value of the functional MRI to detect where the motor or language area is. And if we see this, the image down is 3D of the same functional MRI. You can see the corticospinal tract here is normal. You can see the tumor here, and it's pushing it to this side, misplacing it around this area. So when you are doing the tumor, as I said, we can approach it from the front, but you make sure you don't go around this area, so to avoid injury to the corticospinal tract causing motor problems, because the corticospinal tract convey motor information from the motor area to the spinal cord. In conclusion, preoperative planning is very important before tumor surgery, and there is a lot of advances in the imaging technique now to better understanding of the anatomy and help to have a safe maximum resection of the tumor. I find with the new era of the 3D and virtual reality, a training on brain tumor simulations is very important, especially with this in this time. And I would like to thank all our neurosurgery professors who initiated the era of microneurosurgery and who are teaching us until now how to become efficient and safe surgeons. I would like to thank you all for inviting me. Thank you.
Thank you, Doctor, for your excellent comments. It's an honor for us. It was an honor for us to have him here, and thank you so much.
Thank you.